So we're now going to have an interactive discussion with the panelists, and I'm going to get us started with a few questions for them to answer first. But really, we want to encourage everybody in the audience to participate by submitting questions in the Q&A. We're going to be monitoring those questions. Amy will be, I'll be turning to her to give me some of the questions from the Q&A after the panelists answer some of the questions I have to them. So please participate by hitting that Q&A button and give us your questions. So my first question is going to be sort of a round robin to each of the panelists. And I think we can start with Matt, since he's right up here in front. And my first question is, from the work that each of you have spoken about, what do you think would be your #1 approach to increasing access to complementary care for pain management? And I'm talking about chiropractic, acupuncture, massage, exercise programs like yoga and Tai Chi for underserved individuals living in underserved communities on Medicaid. Matt?
Yeah, so there's enormous interest in exploring all of those alternatives. And I think, it was probably a couple of presenters who talked about, stressing the fact that we're not talking about getting rid of opiates, as a blanket issue, but rather, are there ways that we can either transition people off of them safely or just avoid having that be the only solution that people with pain management get as a first course. There's an enormous amount of interest in looking at chiropractics and yoga and all sorts of other things. But what I think what is going to be really meaningful for my members, for the Medicaid directors, is where is the data to back it up that this works? And we hear anecdotally, and that's great. And that means, where there's smoke, there may be fire, but there's going to have to be more than just the smoke of anecdotally, this works for so-and-so. Because again, Medicaid is a battleship. It is a 70 million person, $600 billion a year program. And turning that battleship around takes time, but it also means you have to be very, very clear about what you're doing, because big changes like that, Medicaid now pays for, chiropractics, or Medicaid now pays for, swimming lessons or whatever, has massive repercussions throughout the healthcare system. And you really want to make sure that you're taking a data-driven approach, that what we're doing clearly and demonstrably makes sense. And I think the second part of that question is, what do we do about it right now? And so I would, per David's point, and I think Kirk mentioned this too, so much of Medicaid is delivered via some kind of managed care plan. And there are multiple managed care entities in any given state. And what I think would be really, really useful is to empower the plans who are much closer to the patient, who have those direct relationships with providers of all stripes, to be able to say, okay, well, United's going to, they're going to have a big demo, they're going to have a big pilot, and they're going to do something, and we're going to study it, and we're going to see, did that work? Did that make sense? And if they did it in Kentucky and it works in Kentucky, then maybe United does it in every state they're in. And if it starts to work like that, then all the other plans will say, oh my God, that's great. We want to do that too. That's, to me, how we really get the ball rolling.
That's great, Matt. Thanks a lot. I'm just going to sort of dig a little bit deeper with you and say, okay, so let's say in a particular state, you had and were shown the data, or your managed care plan really believed in the data and wanted to implement this program. What would have to happen from a Medicaid director standpoint to get it going?
Yeah, I mean, I think it's, states have different approaches to managed care. Some take kind of a more laissez-faire approach of, we've got a goal. Our goal is improved health. We don't care how you get there. You go forth and innovate, be the laboratories of democracy, go figure this out and come back to us. And if you can show us that you have achieved this goal improved health, however we define that, that's all we need. And so a lot of states, either as they're doing the kind of the contracting process or an RFP process with the plans, will either make that kind of explicit or implicit in their relationship or in their discussions with those plans. Otherwise, yeah, it's trying to find the bandwidth to put together kind of a control group and a demonstration and a pilot. State government doesn't have the bandwidth right now to be taking that on. And that's why we really do need the plans to be able to be our force multiplier, to be able to say, you've got the bandwidth, you test this in this area or this population or with this particular alternative to pain, and show us. And when you can show us, it's not just Missouri, the show me state. It's show us that the data is there to back up a decision that is going to shift reimbursement and coverage policy in a big way.
Great, that's interesting, and it's interesting to see how the plans and having the plan sold on it has an effect on the Medicaid population, and I think we'll attack that when it's David's turn to speak. So I'm going to ask Kirk that same question again. From the work that you've done, what would be your #1 approach to increasing access to complementary care? And then, if you were told to implement it in a particular state, how would you do it?
Mm-hmm. Yeah, and I would have to agree wholeheartedly with what Matt just said. It really comes down to the data, so I won't belabor that point. I think from my role at NGA, I work a lot with governors, health policy advisors, and I think if I was asked by the governor to, I'm just trying to be in their shoes to say, okay, I want large-scale pain management delivery reform. I've heard about Medicaid being one avenue. How do I go about doing this? And so I think the approach would be to use the governor's office as the bully pulpit or as the vision setter to also convene and work with the Medicaid director to understand what benefits do we offer, what does our chronic pain population, what's the size of that? Are people going to the primary care physicians for low back pain? Is it neck pain? What are our health systems doing? And working hand in hand with our Medicaid managed care plans, they are great at care management. They're great at care coordination. That is what they sell themselves on. And I think we should hold their feet to the fire a bit and say, all right, well, we have all this evidence. We're wanting to be a willing partner. And so let's try, as Matt said, to do some sort of demonstration. I think there are the realities, though, that states face today of, are we going to have to cut provider rates? And when you do that, you also make it challenging for access to those providers or those services that are provided. So I think it comes down to convening stakeholders, listening to your pain management community. What barriers are they facing? They may have tried chiropractic services, and that's the only non-opioid benefit in a Medicaid plan. And if you have an overwhelming majority of your pain population saying, I need more access, that, I need transportation, I need whatever, it's going to take a lot of creative thinking on behalf of the state to say, how do we provide this to our members in a way that makes fiscal sense as well, and that would be clinically appropriate. So I think it will take time. I think that there are those lessons learned. I think the expert roundtable we held was really instrumental in understanding how states were going about this, but I think more conversations where we're connecting states together to say, how do we move the needle? How do we do this in a resource-constrained environment and going forward? Because the conversation we're having today and the answer I'm giving today is very different than the answer I probably would have given back in 2018 or even in 2019 or even in January. So that would be my answer.
Thanks very much, Kirk. Next, I think I'm going to go to David and have David answer that question.
Yeah, thanks, Cindy. You know, back to the data point of view, I mean, we've convinced ourselves through years of study, actuarial, healthcare economics, clinical, that these therapies are very beneficial, both in terms of quality, cost, health, and well-being. In the commercial space, you know, these therapies are covered, they're available through networks, but they're not used. And to transition this to your question then, which the context really was underserved individuals living in underserved communities and Medicaid. So I reviewed the presentation I gave with our disparities leader last week. And his immediate first reaction was, to the point of taking action and what can we do, it's rather than adding another thing for these already stressed individuals to have to try to pack into their life, we need to focus on removing stressors that will free up time, that will give people the ability to even access these therapies if they are covered. And so that raises housing, food, transportation, education. Many might be single parents. We've got public safety issues. We've got fundamentals of public health. What's the individual support system, social network, mental health? And you know, if we start to address all of those, then we can begin to take on the conversation of, oh, and for your pain, let's go to a chiro. You know, we really can't lead with that until we have the conversation on the first elements. Because this population we're talking about has a number of stressors, and just transportation's classic. If the local chiro is 10 miles away and you don't have transportation, how do you get there? So we need to address those. And I think, you know, once those are being addressed and productively we're engaging on those broader topics, and then we get to the discussion of, you know, people accessing the therapies that we're talking about, you know, the strategy I would encourage, and I think it came up around demonstration, is, you know, some 24-month demonstration pilot. And I would advocate for sourcing local, volunteer, non-prescribing providers aligned with the race, culture, ethnicity of the population being served, to sort of take down the reimbursement barrier. There's a lot of well-intended, strong clinicians that would be on board with this. And so source local volunteer clinical resources. The issue of literacy and numeracy is really important. And so if we were to make an investment, it's develop communication tools for the population we're targeting that help convey, you know, why these therapies may be helpful and put all of this into context. Make access no cost. You know, we in the commercial space last year rolled out benefit plan designs that eliminate patient cost sharing for chiro and PT for back pain, just to take down that barrier, more important in the Medicaid space. And then do the CBA over 2 years. You know, what are the anticipated costs to add these therapies, and study intently the benefits. And total health and well-being is where the benefits are going to emerge. And you need 2 years because this takes time to build momentum around use and medical physicians' comfort in referring for, and how do we build collaboration on a local zip code to make this real for patients. So sort of a 2-year demonstration pilot, sourcing local volunteer clinical talent, and communicating with population served in a way they understand. After the other social determinant issues are addressed, because we just can't add one more thing into people's lives. Long-winded answer, Cindy.
No, it's a great answer. And I think some of that will have Kirk address in the later question that I'm going to ask with follow-up. The only thing that I will say about the social determinants is, when we're talking about pain as severe as what Nicole presented, and most of the people who are our members, you know, the thousands of members that we have, are people disabled by pain. And so while the social determinants are critical, pain would rise to the top of that if you can't even function. And so, for example, when I run support groups, I have people that take the ride, which in Massachusetts is free transportation from underserved communities. They come to the support group so they can learn how best to take care of their pain in order to take care of the other parts, like their children and some work if they can. So pain can be so severe that it really almost outweighs some of the social determinants, such that we need to support that person to attack the others, if you know what I mean.
Oh yeah, yeah, for sure. I'm with you, and I agree. And that gets to the issue of, how do we bring services out to where people are, as opposed to forcing them to go to a bricks and mortar, which could be challenging. And in this space, what's fascinating is the virtual tele, in that I think Matt Taylor is going to do some work coming up. There's some really compelling stuff around yoga therapy and virtual use of yoga therapy to bring services in, assuming people have access to high-speed internet. But some of these therapies are manual. Acupuncture, pretty hard to do virtually. Chiro, hard to do virtually. And so virtual could be a path, but we need to solve for the manual nature of some of these interventions and making it convenient. But I'm totally with you. I mean, if you're in chronic disabling pain, that's at the top of your list. And then it becomes an access issue. So I'm with you.
Great, thank you. So next, Nicole, finally getting to you to sort of answer this question from the patient, from a patient organization perspective.
Yes, thank you so much. I really just have to say to Matt and Kirk and David, you raised some great points and added some interesting context to this. Of course, as Cindy mentioned just a minute ago in her response, we are coming from it from a slightly different perspective, because we are representing patients that are completely underserved right now. And they reach out to us every single day saying that they're unable to access the care that they need. They can't see providers that they want. They're helpless and they're desperate and they don't know where to turn, and they're very, very frustrated with the system as a whole, which I understand. And I know that they're not blaming anyone. It just is sort of the nature of the beast. And so what we are trying to do as an organization is really trying to empower them and educate them along their way. We have a volunteer program that has over 2,000, we call them ambassadors and advocates. And they're individuals living with chronic disabling pain, and they are looking for any way that they can either increase awareness in their local communities, that they can advocate for better options to come. So I definitely think that to Kirk's point and to the report, which if you have not read the NGA report, I highly recommend everyone taking a read. It really is great and fascinating. I think how it talks about the different models that explain Medicaid in different states is really interesting from our perspective, because if we maybe delve deeper into looking at a couple of states that are seeing some successes, maybe we can advocate better, or at least educate those within our community about the options that are already out there that A, they might not know about, and then B, if they aren't in necessarily one of those states that we are looking at, we can help them with tools on how to advocate, whether it is reaching out on the federal side, and or if it's just reaching out locally to their state governors, sharing their experiences and stories to hopefully move that needle and allow them to have the access that they need. So yes.
Thanks, Nicole. Thanks, everyone. So I do have some other questions, but I'm thinking that given the time, I'm wondering what the audience questions are. So Amy, have there been any particular questions that, that stand out that we can take at the top?
Yes, thanks, Cindy, and thanks to all of you. This is just fascinating, and the chat is strong and people appreciating all of this information. There's a number of questions. Let me start with one that came from related to massage, and this question is from folks at the American Massage Therapy Association. When asked which providers pain patients would like to see but cannot because of barriers, massage therapy is at the top of the list. Likewise, massage is covered by Medicare Advantage but not traditional Medicare. How can we improve states' awareness and utilization of massage therapy as a non-opioid pain treatment for Medicaid patients?
Okay, so I'm going to go to Kirk first to answer that one.
Oh boy. Yeah, so we do review the evidence for massage therapy in the report. There is, it is helpful for certain conditions, but I would note it's not a silver bullet, just like opioids are not a silver bullet. A lot of what we talked about or discussed at the roundtable was the need to reorient how we think about pain and shifting from alleviating pain in the near term to restoring functionality and empowering people to go out to work, to live their lives, to take a walk with their grandkids. So I think to the coverage decision, yet Medicare Advantage, kind of like MCOs, they have a little bit more broader flexibility than what is provided through maybe Medicare Part A or Part B. But I think that those decisions need to be tied to mental health parity. We need to recognize that it's going to take a shift in someone's mind to how they think about pain, how they experience their activities of daily living. And massage is one tool, but it also needs to be paired with psychotherapy services and really working with the patient to understand the drivers of their pain. So hopefully it's one tool in the toolbox that plans are looking at, that the federal government's looking at, states are looking at. But I would say it's probably not a silver bullet, but it is one tool in the toolbox.
Thanks, Kirk. And David, I'm wondering if we could follow up with you. Do you have a different perspective on that question or something to add? How, if patients in the survey we found most want massage, but we also know that's almost never covered. What would you do to change that from a payer perspective?
So again, I'll offer you my opinion as opposed to the formal UHG position, but massage is something we're looking at. Employers and their members are wanting this massage benefit for good reasons that we've talked about today. And then we distinguish between sort of the soft tissue-based manual therapies that PTs, chiros, other providers provide today and is covered today. So then there's a line into, quote, massage benefit. And when we talk about coverage, it's not only covering the service, but it's all the infrastructure that goes with it. So what providers are qualified to deliver the service? What's their training? Is there licensure and malpractice infrastructure to build a network and vet providers so when consumers go, they know they're going to a licensed provider with malpractice insurance in a setting that meets minimum ADA standards. So coverage is actually a really complex topic, and very few would disagree with the notion that massage therapy is beneficial for people. It's how you move that to a covered benefit and bring in all the infrastructure that goes with it that needs to be solved for. And I'm not as well versed in the whole licensing infrastructure for massage therapy in all 50 states across the country and how uniform are the standards and how might you vet that. And our massage therapists populated in CAQ8, so there's a source of provider data. There's just a number of elements, Cindy, that go with the issue of coverage that, in my mind, still need to be solved for. But the modality itself, super beneficial.
Okay, great. Thanks, David.
Yeah, actually, if I could jump in there, just make some wrapping around comments. I think, we often say, elections have consequences. Well, coverage decisions have consequences too. And when Medicaid or Medicare or any big payer sort of comes along and says, we are now covering X, that creates, significant ripple effects, some of which are very good. You get more access to X. People who are doing X are going to get paid more. But it also does tend to create, if all you're doing is focused on a service or a modality, it kind of creates people, trying to maximize that. And this is just basic, I'm not blaming anybody. This is economics. This is capitalism at work. When you create a revenue stream for something, you're going to drive a lot of people to focus on that one thing. And I think one analogy is, as we've struggled in the past to kind of think through, how are we treating autism? And then CMS came along and said, well, every Medicaid agency must cover autism, these defined applied behavioral therapy services, and just kind of left it out there. This is a coverage decision. And what we saw was costs just absolutely exploding with very little connection to those costs and those additional treatments actually creating better health, actually fixing something. Rather, it was just like, I'm gonna follow the money. So that's why I just say you gotta be careful about just sort of saying, well, we're covering X, mission accomplished, let's go home. Rather, and I think a number of other people have really hit on this, it's how are we thinking more holistically about the individuals? Because massage therapy may be good for me, but not you. And, you know, equestrian therapy may be good for you, but not me. You know, I think the key is to really empower somebody to say, we're going to figure out what it is that's going to help Cindy get back on her feet physically and kind of emotionally. And that may be a little of this, it may be a little of that. It's going to be, it's a social determinant of health issue. That's not, and that's why I think it's important to say Medicare doesn't do this, Medicare Advantage does. That's the analogy here in Medicaid too. Medicaid may not do this, but plans, MCOs are gonna have the flexibility to kind of say, you know what, we're closer to you as the patient. We're gonna be able to, let's try to figure out what it is that you need and craft a, you know, a personalized plan of care that will hopefully be data driven, but will be flexible enough to be focused on an outcome as opposed to we're covering X service and our job here is done.
Matt, that was a great answer to remind us about the holistic approach, because we do want to go back to that. You know, certainly, like you're saying, one modality might help somebody, but not somebody else. And so that managed care approach, I think, is really sort of, we're pointing in that direction. And it's a good point you also made about the economics of doing this, you know, and how that sort of changes the availability. So thanks very much for that. Nicole,
Cindy,
did you have anything to add?
Cindy,
yes, go ahead.
apologies for interrupting you. We won't be able to do this very often, but Janet Kahn has something she'd like to mention around this. I think it's pertinent to this discussion. She is a massage therapist working at the Comprehensive Pain Program in Vermont that is a partnership with Blue Cross Blue Shield and the University of Vermont Medical Center. And Vermont Medicaid was in the conversations to potentially be covering this program. I am going to hope this works. I'm going to click answer live and see if that allows Janet to be able to just quickly give some comments. Janet, are you available now? Let's see. Maggie, can you help me find Janet and make her available? Janet Kahn, if I didn't do that correctly.
Okay, am I audible now?
Yes, we can hear you.
Great. Okay, so this is obviously going back to the issue of massage therapy. And what I wanted to say is two things. One is it's clear from my personal conversations, and also I've seen one survey, but I can't locate it right now on the computer, that one of the concerns about massage therapy by both payers and potential referrers, PCPs who might be referring, is the relatively short duration of the basic training, which is the requirement in most states for licensure. So I want to say to the American Massage Therapy Association, which I know is a partner in this conference, that I think the AMTA and the National Certification Board should take some responsibility for creating what is now being left to private entities to create, and that is some specific training, both certification in pain management and in clinically based massage, so that people really become prepared to operate in the context of a clinical team. So it's really that I wanted to say.
Great. Thanks very much. That was great that we could go to Janet. Thank you, Amy. And, you know, some of this will be really interesting to sort of approach in the afternoon panel with Sherry Ling, because we all know that for chronic low back pain, there is going to be Medicare coverage for acupuncture. And so it's going to be interesting to see both the economics of that, the accessibility of that. And we do know that people that are severely disabled by pain, which is largely our population, do have access to Medicare. So it will be interesting to see that what changing that one modality has. Amy, are there any other questions that pop up? I definitely have some other questions I wanted to ask, but I wanted to see if there are ones that you think would be interesting for most of our audience.
I am trying to see which have not been answered. I know a general question around the level of evidence and research, stating that the claim that we're always looking for more data has been said for a long time, that often contributes to lack of access. And there is so much evidence available now, as we're seeing, large payers, include these therapies in their care. So I think people are wondering, what's really the deal there, with research and data, and what advice around helping researchers who intentionally want to find the right research to get there.
Yes, so that's interesting because it's very much in line with the question I was going to ask that I think is even more specifically at that, and it's for David, right? So David, from the illuminating work that you and your colleagues at United Healthcare have done, you seem convinced that coverage for comprehensive pain care with a focus on non-invasive complementary care is really the best approach for patients and payers. Yet we hear most payers are reluctant to move toward covering these treatments, largely because of this evidence issue. What would you say to the CEOs of payers and the directors of Medicaid programs to convince them that this is the way to go, like United Healthcare is convinced?
Wow, how much time do we have left? This is a big one.
About 10 minutes, but I wanted to get some more questions in.
Yeah. So again, I can share just what my experience is. And so for the typically covered therapies, PT, chiro, acu, mental health, most commercial insurers are covering these therapies. Naturally, coverage comes with it some limitations. Chiro's typically 20 to 24 visits, PT 60, acu 10 to 15 visits. There's selective for look, there's real fraud, waste, and abuse that happens in these therapies. And as a fiduciary protecting sponsors, whether they be government agencies or employers, there's a need for in this space. There is some unbelievable activity that happens out there. And so is needed. So from a payer perspective, we've convinced ourselves there's been a number, I've been trying to pay attention to questions, a lot of questions on data. Isn't there abundance of data? Yeah, there really is. And we've convinced ourselves through years of heavy analytic work that these therapies spin off a number of cost, quality, health, and well-being benefits that more than offset the cost of the services themselves. So that data is settled science in our view. I mean, in fact, we've sort of been told that, hey, stand down and spinning up more analytics on this. We already have a very clear point of view on the value of these therapies. Some of the other ones we've been talking about, yoga therapy, massage, we're intensely interested in studying these, and we have some work underway to understand the value of these therapies, which then informs coverage. Other entities, VA, and they're doing some outstanding work in this space. We're going to hear from Medicare later on some innovative work Medicare is doing to expand coverage in this space. So I think payers are kind of there, that there's value in these therapies and they should be covered. So I'm a little bit random here, but what would I say to the purchasers? At this point, and setting aside the random, sort of poorly executed RCT, randomized trial, which they're still happening, and really, frankly, just introduces static into the environment. That's not helpful. I really think there's near universal agreement on the benefits of these non-pharma therapies. I think it was Matt earlier that just raised the dynamic that budgets are tight. Reducing cost is the focus, and there's a lot of competing priorities. And you add an autism benefit that dramatically increases the budget for a state, and you want to go to them and talk about covering massage therapy now? Wow, that's a tough conversation to have. So the economics are really what drives the attention. But my sale to a CEO or an employer would be grounded in all the data that we have that demonstrates really the unquestioned benefit of these therapies. And it frankly is pretty black and white. And then you need to get over the hump. If I'm going to add this benefit, which translated in their mind is to a new line item with added costs on an already tight budget, you need to have patience, because the return for these therapies is not going to show up next quarter or next budget year. It's going to be 2 years plus to be able to prove a return on the investment that a CEO or a local government is making. And so I don't have an easy answer. It's not an easy conversation to have. The data is clear, the benefits are clear, budgets are tight. It takes patience to get a return on the investment you're making in these therapies. You have to have an innovative leader that's willing to take a 2-year run at it.
One thing I would add to that is just the interesting nature of putting this group together, because I would say with the slide that Nicole presented, where patients in long-term severe pain, and most of the people answering that had spent 10 years looking for help, most want these complementary therapies, as we've seen, right? And what we've seen in David's data is that most of them are offered surgery or injections right off the bat, which are covered. Like, those are the most expensive treatments possible. And I know from the perspective of knowing, hundreds of people living in chronic pain, that isn't what they want first. There's such a cost-effective argument in that when you look at David's data showing that surgery, injections, and medications are the things most offered, yet Nicole's data of people with most experience living with pain want complementary care, to me, that just makes a cost-effective argument right there.
Yeah.
But we'd have to combine our work.
Hey, Cindy, one more just quick comment? And I know it sounds through the questions, there's a number of researchers on here, and I've been pretty transparent with Amy that I think, and to your point exactly, the research in this space needs to open the aperture and not get so focused on pain control, but look at total health and well-being, blood sugar control, proteomic markers of inflammation, and the ability of people in chronic pain just to be able to move more spins off these health and well-being benefits around BMI control, better blood sugar control, better control of inflammation, better mental health and well-being, that downstream over 1, 3, 5 years has health and well-being benefits that need to be quantified to justify the expense of adding this as a covered service. If you're just going to do it to try and look at offsetting reduction in opiate prescribing, there's just not enough money there to demonstrate the CBA. You need to look at impact on diabetes and cardiovascular disease and other condition categories, which I think is real, and that's the space that we're pretty focused on.
What do you think about my argument about the surgery issue? Because I can't even tell you how many failed back surgeries we see in the pain space, yet those have got to be way more costly than covering massage.
Yeah, it's, I don't know what the average episode cost for surgery is, $40,000. Average visit to a massage therapist is going to be what, 50, 60, 70? I'd say it's under reimbursed, but that's kind of where the market is. You can buy a lot of massage therapy for $40,000 surgical procedure. And when you look at the cost experience pre and post surgery and the 1 year run up to and the 1 year follow, in many cases, surgery is not that helpful, to your point. In the spine space, you can buy a lot of massage for that, keep people functional and have better blood sugar control and keep people more functional. So I'm with you.
Yeah, no, good point. I mean, I guess, a lot of physician, particularly surgeon groups would not be with us, but that's what we're up against with something like that. We still have a few more minutes left, and I had a question I'm just dying to ask Kirk. So unless, Amy, there's something that you think really comes to the top, I wanted to end with this question to Kirk, because it helps us, make the rubber hit the road.
You bet.
So-
I'm gonna give that to you, Cindy. I just want to quickly say, though, no time for a question here, but with this last piece of discussion, I think it highlights also the need for interprofessional education related to all these therapies, because as Kirk said, it isn't a silver bullet of any one or another. This is a comprehensive approach, and all these things matter, and they matter when you have healthcare providers that understand how to work together. So I just want to throw that in, because I think that's imperative, for us to stay connected with, and how we can help on that end too. So please go ahead, Cindy.
Great. So Kirk, I was intrigued in your report about all these innovative strategies that specific states have used for expanding access to non-opioid pain management. Everything from incremental expansion to Medicaid managed care partnerships to the health homes that you talked about to the waivers. Could you give an example of a particular state that has successfully used an innovative approach that you think is most easy to replicate in other states?
Sure, with the caveat that none of this is very easy to do. I was most impressed probably from Rhode Island. They had an 1115 demonstration where they partnered with the MCOs to provide complementary approaches. So massage therapy was one, acupuncture was another, chiropractic services, to qualifying beneficiaries. And they determined in their analyses, MCOs examined those patients that were showing up in emergency departments 4 or greater times in a 12-month period, and targeted those individuals to offer those services. And so at the end of the demonstration period, Rhode Island decided not to renew the 1115 demonstration waiver, but they did decide to continue the partnership with MCOs. They both cited reduced emergency department visits, which we all know is highly costly. And so this generated a return on investment. And so I think it goes to show that health plans, and particularly Medicaid managed care plans, are very integral in this work. They provide coordinated care. I think we also need to remember the pain community. It's not monolithic. Individuals may come with trauma. They may have PTSD. That won't be solved by adding massage therapy as a benefit. We have to take a whole person approach. And I think by offering the services with the most robust evidence, and providing a nurse care manager to coordinate that care and to make that patient feel like the system is working for them, I think that is where you're going to find success.
Great, thanks a lot for that example. And I'll be following up with you and getting the Rhode Island contacts after
happy
this.
to. Yeah, happy to, yeah.
Well, thank you, Cindy. Thank you. Thank you so much. You did a fantastic job moderating this session. Really, hats off to you, and thank you.
Hats off to the speakers. I mean, and the speakers were fantastic. Thank you, all of you, and Amy, for putting together this set of speakers. I think it was just brilliant. So thanks.
Well, absolutely. This is exciting to put together, and that's when we all get in the same room. It really does just illuminate different things, and it really triggers a lot of different opinions and thoughts. So we appreciate everyone seeing this, through our chat feature and Q&A. We now have a brief break. We will start again at 1:15. Please log in just a few minutes early. Matt Taylor is going to grace us with a few minutes of breathing to center us for this long and productive day we're having together. So we'll see you in a few minutes. Thanks all.